Good day everybody, I'm Blessed Elaine Ipla, and for today's video, I'm going to be talking about electrolyte imbalances, specifically calcium imbalances, magnesium imbalances, and phosphorus imbalances.
So I'm gonna be talking about the definition, the etiology or contributing factors, the pathophysiology, the signs and symptoms, the complications, the diagnostics and laboratory procedures, the management including the medical, surgical or pharmacologic, nursing diagnosis and nursing management, and the prognosis. So what is calcium? More than 99% of body's calcium is located in the skeletal system. It is the major component of the bones and teeth. It plays a major role in transmitting nerve impulses and helps regulate muscle contraction and relaxation, including the cardiac muscles. And it activates enzymes which create chemical reactions in the body. The normal total serum calcium levels is 8.6 to 10.2 milligrams per deciliter, and the normal ionized serum calcium levels is 4.5 to 5.1 milligrams per deciliter. Let us talk about the endocrinology. So the endocrine system has these endocrine glands, and these secrete hormones, which produces particular responses to maintain the homeostasis in the body. The major endocrine glands include the pituitary gland, thyroid gland, parathyroid gland, and others, but we will focus more on the parathyroid gland. The parathyroid gland secretes parathyroid hormone, which is responsible for the regulation of calcium and phosphorus metabolism. The increased secretion of parathyroid hormone results in increased calcium absorption in the kidney, intestine, and bones, raising serum calcium levels. Now, what is hypocalcemia? Hypo meaning under, low, or less. Cals, a prefix for calcium, and emia meaning blood. Therefore, it is termed as the low calcium level in the blood, or less than 8.6 milligrams per deciliter. The contributing factors include hypoparathyroidism, malabsorption, pancreatitis, alkalosis, vitamin D deficiency, chronic diarrhea, massive subcutaneous infection, and alcoholism. The pathophysiology. Here for the hypoparathyroidism, there is decreased parathyroid hormone secretion, which could result to a decreased calcium secretion and may lead to transient hypocalcemia. Another is for the kidney injury, because patients frequently have elevated phosphate levels, and if there is increased phosphate, there is decreased calcium. The signs and symptoms include positive trousseau and Schwarzschild sign, tingling of fingers and toes, diarrhea. Others include seizures, carpopedal spasm or the involuntary muscle contraction, decreased BP, anxiety, impaired clotting time, and for the ECG there is prolonged QT interval, lengthened ST segment, and for the laboratory result there would be a decreased magnesium level. The complications may include tetany, basal ganglia calcification, Parkinsonism, hemiballismus, chorioathetosis, others. The diagnostics and laboratory procedures. To calculate the corrected serum calcium levels, here is an example. A patient's reported serum albumin level is 2.5 grams per deciliter. The reported serum calcium level is 10.5 milligrams per deciliter. First is you have to calculate the normal serum albumin level from the normal. Example here is the 4 grams per deciliter minus 2.5 grams per deciliter is equal to 1.5 grams per deciliter. Next, the following ratio is calculated. So 0.8 milligrams per deciliter. This is the equation. X milligrams per deciliter, and then the 1.5 milligrams per deciliter. So X is equal to 0.8 times 1.5 milligrams per deciliter, and then 1.2 milligrams per deciliter is the outcome. Finally, 1.2 milligrams is added per deciliter is added to 10.5 milligrams per deciliter. This is the reported serum calcium level. And to obtain the corrected total serum calcium level, you have to add 1.2 milligrams per deciliter and then 10.5 deciliter, including 11.7 milligrams per deciliter. Another is serum ionized calcium, serum electrolytes, parathyroid hormone, vitamin D metabolites, and electrocardiogram for the heart rate and rhythm. The management. For the medical, under the pharmacologic is the IV administration of a calcium salt, calcium gluconate, and calcium chloride, and these restore serum calcium levels. But be careful because it is dangerous to patients receiving digitalis derived meds because it has similar effects to digitalis toxicity. 0.9 sodium chloride should not be used with calcium because there will be an increased renal calcium loss. Solutions containing phosphate or bicarbonate should not be used. Patient is kept in bed during IV infusion and BP is monitored. Nutrition therapy, vitamin D therapy, aluminum hydroxide, calcium acetate or calcium carbonate antacids, and you have to increase calcium dietary intake of at least 1,000 to 1,500 milligrams per day, and the calcium-containing foods include the milk products, the green leafy vegetables, canned salmon, sardines, oysters, and others. Nursing diagnosis and nursing management. First is risk for electrolyte imbalance hypocalcemia related to diarrhea. You have to monitor heart rate and rhythm, monitor for trousseau and Chvostek sign, discuss the use of laxatives and antacids, assess neuromuscular strength, tone, movement, and reflexes, stress importance of meeting calcium needs, especially the dietary intake, and encourage stress reduction and relaxation techniques. And for the collaborative is to administer meds as indicated. Another is anxiety related to altered health status. You have to monitor the patient's mental status closely, encourage verbalization of feelings, use presence, touch, verbalization, and maintain empathetic attitude. You have to lessen sensory stimuli by providing quiet and calm surrounding and encourage positive self-talk. Others, you have to include seizure or safety precautions, status of airways closely monitored, and education about foods high in calcium. You have to remember that increased doses of caffeine and alcohol inhibit calcium absorption, and caution to avoid overuse of laxatives and tests that contain phosphorus. Prognosis, it depends on the underlying cause, the severity, how it rapidly develops, and presence of signs and symptoms. It is vital to be aware of the underlying causes to be treated and managed early. Now, what is hypercalcemia? Hyper meaning above, excess, or high. Cals, a prefix for calcium, and emia meaning blood. Therefore, that is termed as the high calcium level in the blood or is greater than 10.2 milligrams per deciliter. The contributing factors may include hyperparathyroidism, malignant neoplastic disease, prolonged immobilization, overuse of calcium supplements, vitamin D excess, and digoxin toxicity. The pathophysiology. Here, for the hyperparathyroidism, there will be an increased parathyroid hormone secretion and there will be an increased release of calcium from the bones, leading to an increased intestinal and renal absorption of calcium, which could result in hypercalcemia. Another is for the immobilization. Once the bone mineral is lost, there will be an elevation of total, especially ionized calcium, in the bloodstream. Signs and symptoms include muscular weakness, dehydration, hypoactive deep tendon reflexes, constipation, anorexia, polyuria or frequent urination, and polydipsia or extreme thirstiness, nausea and vomiting, lethargy, deep bone pain, pathologic fractures, flank pain, hypertension, and for the ECG there is shortened ST segment and QT interval. Bradycardia and AV block may be manifested. The complications may be osteoporosis, kidney stones, kidney failure, nervous system problems, and abnormal heart rhythm. The diagnostics and laboratory procedures are double antibody parathyroid hormone test and X-ray. For the management, for the medical is to treat the underlying cause. Example here, chemotherapy for malignancy. For the surgical is partial parathyroidectomy for hyperparathyroidism. And for the pharmacologic is to IV administration of 0.9 sodium chloride solution, IV phosphate, furosemide for diuresis, calcitonin derived from the salmon, intramuscular testing is necessary, corticosteroids, mithromycin which is a cytotoxic antibiotic, and inorganic phosphate salts. Nursing diagnosis and management. First is risk for electrolyte imbalance, hypercalcemia related to hyperparathyroidism. You have to assess the level of consciousness and neuromuscular status, monitor cardiac rate and rhythm, monitor intake and output, provide safety precautions, restrict sources of calcium-rich products, such as dairy and others.